you take your seats, we get started. Okay. Thank you. Just to make sure you're all where you want to be and need to be, this is a session on whether direct financing for public health facilities can improve the availability of health products. So the session about money and drugs, basically. So I see we have a good turnout interested in that topic. My name is Nirmala Ravishankar, and I'm a senior fellow at Thinkwell. We, Thinkwell, that is, are organizing this session with two partners, the Center for Global Development, CGD, and Khemri Wellcome Trust. So I want to quickly acknowledge and thank our collaborators from there, as well as our team at Thinkwell, who've been helping behind the scenes on the communications and outreach for this session. So just to kind of provide a quick framing for why we decided to put this together, it's really about bringing two communities of people sort of asking the same question together to have a joint conversation. And the two communities, first, there's the sort of community of health financing people. I suspect those are the folks in the room today. We've been talking a lot about this topic of direct financing for health facilities. How do we get more resources to frontline facilities so that they can use those resources flexibly to source for the kinds of inputs they need to deliver high quality services? And in some ways, this is a reaction to the traditional mode in which public facilities have been funded in many low and middle income countries, where essentially a government agency, either a local government or the Ministry of Health, pays for inputs like health workers, commodities, and provides them to the facilities. And so there's this growing recognition that facilities ought to have some resources that are their operating budget that they can use more quickly, flexibly to get what they need. The Lancet Global Health Commission on PSC financing, for example, found that facilities have the mandate to retain and spend funds. Lower level facilities have the mandate to retain and spend funds in only about 40% of the low and middle income countries that they serve. So that's been sort of the topic that we've all been discussing in one room, so to speak. But there are important questions even in that conversation about what facilities can do with those funds. So it's not just about getting the money to the facilities, but what rights do they have? Or as a recent World Bank report put it, what is within the locus of control of the facility? So if they can't spend the funds to manage health workers, or if they can't spend the funds to source for commodities, we're not going to see major changes in those areas. So it's about what they can control and, frankly, how much money they have. If you don't have a huge operating budget, then you're not going to be able to deal with all the stockouts or deal with all your needs. So that's the kind of conversation that we have started to have in the health financing community. And separate from that, amongst supply chain folks, whom I didn't know too well before we started putting this session together, there's been a conversation about the fact that in most low and middle income countries, the supply chain system has been set up to be very centralized, with a central medical store dealing with all the steps in the process. And while that kind of centralized method has a certain economic logic about food procurement, lower transaction costs, there's been a growing recognition that while that centralized approach leads to better prices or lower prices, it doesn't always result in availability of commodities on the front line. And so there's been a discussion, and we'll hear more from my colleague Prashant in a minute, a discussion in that community about how to perhaps involve facilities more in the process in order to address the availability issue. But there are also simultaneously concerns that if facilities start playing a bigger role, maybe that will improve availability, but will there be a trade-off, say, with the quality of the commodities that they have or the prices they go up? So that's sort of the conversation that's been happening in alternative room among supply chain folks. And so in this session, we're trying to bring these two communities together to first look under the lid and understand how these arrangements happen at the facility level, to understand, and this is really an empirical question, whether giving facilities a bigger role leads to improved availability of commodities while not sacrificing on quality and cost. And what kind of evidence do we need to garner to further this agenda? So that's the objective of this session. And so to help us do that, we have an amazing lineup of folks. I'm going to be facilitating the first segment of this morning. It's a roundtable discussion with a range of health financing experts as well as supply chain folks, and I'll introduce them all in a minute. And that will run till about 10 a.m. And then we have a panel where we'll hear about evidence from 3 countries, Tanzania, Nigeria, and Indonesia. And my colleague Anne will be facilitating that, and she'll introduce the speakers then. And then we'll have a last sort of 30 minutes to hear from 2 leading thinkers on health financing about what are some outstanding questions we need to answer, how do we take this agenda forward. So with that, I'm going to, actually, before I introduce all the speakers, I do want to take a quick minute to note an issue about terminology. So in this session, as we bring these 2 communities together, you'll hear the word purchasing used in a couple of different ways. And I just want to flag that right up front. So for health financing people, when we say health purchasing, we're talking about how agencies that pool resources, the Ministry of Health, a National Health Insurance Agency, or a local government, how they allocate those resources to providers of health services and how they make those payments. But in the supply chain community, the same word, purchasing, is often used to talk about procurement, or words are often used interchangeably. And in that case, we're talking about how producers of health services are accessing the inputs or accessing commodities and how they're paying for those. And in the private sector, you can kind of think of these as 2 distinct markets, right? If you think of health facilities in the middle, one market involves health facilities and the purchasers of health services, how the facilities are getting paid for services, versus the second market, which is about how the health facilities get access to commodities and how they pay for it. In the public sector, it's a little more complicated because you have the purchasing agencies actually sourcing for and procuring the inputs and providing it to the facilities. So it's, the sort of neat distinction between 2 markets sort of breaks down in the public sector. But I just did want to flag this issue about terminology. So we'll hear the word procurement and purchasing being perhaps used in slightly different ways as different people speak about this topic. Okay, so with all that background, let me introduce our first panel. We have from the supply chain end of things, Prashant Yadav, who actually was one of the organizers of this session, but he was not able to make it to Cape Town for some unforeseen reasons. So he did send in a video clip that I'll be playing in a second. Prashant is a senior fellow at CGD. He's also the affiliate professor of technology and operations at INSEAD. He's a globally recognized researcher and policy advisor in the area of healthcare supply chain. We also have from the sort of health financing community, Edwin Baraza, who many of you probably know. He's the director of the Nairobi program of the Kennedy Wellcome Trust Research Program. He heads the program's Health Economics Research Unit, and he's written extensively on this issue of facility autonomy, the lack of it, the importance of it, the limits of it, etc. So we have Edwin. Then we have Nirtila Travanji from the Global Fund. She's the manager for health financing in the high impact and Southern African countries at the Global Fund. She supports about 35 high burden countries implementing sustainable financing solutions, for the three main diseases, but also health system strengthening. Before the Global Fund, she worked at UNAIDS and WHO, and she's been thinking a lot about the DFF work or the direct facility financing work that the Global Fund is funding. And then back from the supply chain end of things, we have Javier Tomsech, who is the supply chain lead at the Bureau for Global Health at USAID. He's also worked extensively on supply chain for medicines and health supplies in a range of countries, including extensively in Francophone Africa. He's going to be joining us virtually, and we thank him for waking up at 3 in the morning to join us from Washington, D.C. He also, in my opinion, gets the award for the best profile picture on this slide. Okay, so now I'm going to be turning the video from Prashant, who sends his apologies for not joining in person, but has shared this video. Do I need to click anything more?
That's fine, it's fine.
Which are not necessarily new, and some things have emerged in the last few years which are new. I understand you all have the privilege of being in person, so I can imagine.
Apologies for this.
In the 5 minutes is good morning, everyone. My name is Prashant Yadav. I am an academic that focuses on healthcare supply chains. What I want to share with you for the next 5-7 minutes is some ideas and some evidence on autonomy or greater autonomy to health facilities in making their ordering and purchasing decisions and how it impacts availability. Some are ideas which are not necessarily new, and some things have emerged in the last few years which are new. I understand you all have the privilege of being in person, so I can imagine how unpleasant it can be to listen to somebody who's showing remotely. So I'll try and condense this into as short as possible. The paper, these slides are available in case any of you want to look at this in greater detail. Portions of this work are jointly with Nila Yashi in her independent capacity before joining USAID. Okay, so a few key things in case I lose you for the rest of my 5 minutes. One is we have a real chance to think about a slightly different model in which health facilities, the lowest level health facility, primary care centers, can order supplies, medicines, other health products directly from suppliers with whom a central aggregate agency at the regional, provincial, national level has pre-negotiated price, supplier quality, and delivery terms and other contractual and performance management conditions centrally, and the ordering happens directly from the facility to the supplier. Some of this has been shown to work better in terms of improving availability in the DFF and the performance-based financing pilot projects and programs in a few countries. The concerns that have been raised in those programs have been, sure, the facility purchasing directly improves availability, but what about quality? What about the price they're paying? What about supplier selection? So I think we can find a hybrid approach in which both of those benefits can be brought together. There are a few examples of that happening. Admittedly, the political economy of making this happen in a given health system can be complex, but at the same time, it doesn't mean that it is not something that can be navigated through clever management and clever techniques of bringing out the evidence that is needed to move this forward. Okay, so this is not new in all of OECD countries. Sweden used to be an exception. I have a case in Sweden separately. The contracting supply selection functions are carried out by a central agency, which is the BEAR. And the task of actually delivering medicines is carried out by private wholesalers with whom the contracts have already been put in place. For a variety of reasons, such as the wholesale market not necessarily working effectively, it is not having enough reach and equity, and it's not necessarily an area where we have good and sufficient controls over quality. Because of that, in a large number of low-income countries, the structure that we see is all of the functions: price negotiation, supplier selection, transport, storage, distribution, ordering, inventory management, verification of delivery. All of those functions are carried out by different levels in the government-run supply chain. And what we are going to talk about is there an opportunity to shift some of this to a structure that will look like this? Again, not a new conversation, but many things in the health systems today have changed in terms of technology, in terms of help of the private distribution market, the emergence of new players, some new evidence, which may enable this better now. So Mira and I looked at what are the key steps. Some are strategic, which are about identifying suppliers, getting an understanding of the market. So essentially market insight, supplier selection, and price negotiation functions. And then the others are functions which are about getting products to the health facility in time, right quality. And I think what we've got to ask is the question, what combination of these activities is the best way to organize the system? I think the 4 or 5 predominant ways that we look at are either about all of these activities being carried out in the same agency or same entity, or some distribution of those tasks across entities, which is not necessarily the best from the perspective of improving availability or other outcomes, but is designed to mimic what the health systems administrative structures look like. So we can question that. There is some evidence, including some of our own work in the past, which shows that changing the structure helps. One particular kind of change we are talking about here is allowing health clinics to purchase and order from suppliers. And we have to distinguish between procurement, which is a clubbing of purchasing, ordering, supplier selection, price negotiation, contract performance management functions. Whereas what we are referring to here are ordering and purchasing, which are, if a central contract is in place, the facility can then order, pull off from that pre-negotiated contract. So we looked at about 15 countries, and out of which we did a deep dive in 6, where we looked at some different models of decentralized purchasing, some combined with financing. The facility had its own financing, some the facility did not necessarily have financing, and we looked at models which included a prime vendor, which means a central agency selected a set of pre-vetted suppliers and predetermined price, and models in which that function is carried out more directly by the health facility itself. More details of this are in our 2002 paper, which I'm happy to share with all of you. But in summary, what we're finding is if there is greater autonomy for health facilities, in particular in purchasing and ordering, it improves performance, in particular on availability. But if it can be combined with pre-vetted supplier selection, right, contract and price negotiation, it also improves price and delivery lead times, and perhaps even supply chain resilience, because it provides more flexibility to the health facilities. All of this requires the health facilities to have forecasting, ordering, and inventory management capabilities at the health facility. This is an area where technology and companies who are service providers for such functionality to health clinics, including in the public sector, including remote areas, those companies have grown in numbers and size and reach. And so that's what has created a new opportunity. Secondly, this depends upon the private supplier having the ability to distribute and distribute with integrity and distribute with proof of verification. Once again, new players have emerged with new business models and new technology to carry out this role. So that's once again makes the distribution market more ready than it was in the past. What we need is stronger evidence and a tool which can help us assess in which countries does the health facility side of the equation, the distributor market side of the equation, and the overall political economy of procurement purchasing, are those factors ready to carry out such a decentralized ordering and centralized negotiation. We've had attempts of doing this in Ghana. We've seen a direct facility distribution model in South Africa, which has shown good performance measures and metrics. So I want to leave you here with ideas to reflect on throughout this side session, and hopefully you all come up with new ways of at least moving forward on this sentence. Thank you very much.
Perfect. Thank you so much. Well, I don't know, Prashant recorded this obviously before and he's not awake right now. But we thank him in attention. I'd like to invite Edwin and Nurtila to the stage to have a discussion. And Ravi, if we could have the Zoom session up on the screen, because we have one discussant joining us virtually. Thank you. Would you be able to just confirm that the online participants can hear us comfortably?
Nirmala's mic isn't working there.
Is
Her mic up there isn't working.
which one? They need to put on that side. Need to open. Okay. It's open now. Hold on. Let's go.
If needed, your man. Okay. So we've sort of heard down that because of training of writing process, and I wanted to start with you, Edwin, in terms of you're sort of representing the health financing community in this discussion. We've all been talking extensively on this topic of financing. In terms of thinking about linking that to service readiness, availability of commodities, and importance of trade, how should we be conceptualizing this section, thinking this in the right way?
Thanks, Nirmala. I guess a couple of issues. One, from our financing perspective, as you mentioned, one of the things that is currently debated is the issue of financial autonomy. So the need for decentralized levels, districts, counties in Kenya, and health facilities to have financial autonomy. But then the question has always been financial autonomy for what? Because once you're given resources, the reason you're given control over resources is so that you can be able to carry out certain functions. And so the idea then is that you should have operational autonomy as well. And when we think about operational autonomy, it's operational autonomy to carry out specific functions at the facility level. And one of those is procurement autonomy. So autonomy over decisions around how to procure and many other things. So that's one. So financial autonomy is quite linked to autonomy to specific decisions, including procurement. And when it comes to procurement autonomy, I think it's really quite important to, again, there is this assumption that we're talking about attention between providing the benefits of centralized procurement. I think it's generally accepted that when you have pooled procurement, it does have certain advantages, including improved efficiency and so on. but there's also a need for some flexibility because of everything is centralized and controlled, and your challenges with the agility of managers at a lower level to make decisions. And so when we approach the issue of procurement autonomy, it's quite important for us to recognize that it's not a black and white phenomenon. It's really not about, we're not talking about whether the decision to procure should be at the central level or, sort of central medical store, national level, or decentralized county district level versus at the facility level. That's not really how we should be looking at it. What we should rather be looking at is what are the decision rights along that, the range of functions that procurement comes with, and what is the right configuration for allocating those decision rights to facilities and to various other levels. And here, and I think Prashant has talked about this a little bit, we are talking about, functions around selection, for instance. Now, the way typically, facilities would select commodities in low and income countries is through the development of essential medicines list of formularies. And there is advantages to that because, there is evidence that goes into selecting a list of medicines that a country needs. But there is also the fact that even within countries, you have heterogeneity of needs. So once you get to decentralized levels and to facility levels, you have certain needs that might not always be captured at the national level. So the question is, there is an advantage for a centralized selection process, but there is also some advantage to allow some flexibility at the facility level for people to be able to make decisions about supplementary needs or additional things that are more responsive to the needs, of the local communities at that level. And there's a lot of precedents for that. So, if you look at sort of health facility reforms and hospital reforms, you had the role of medicines and therapeutics committees at facility level that get to make certain decisions about additional selection of commodities. Then we have quantification and forecasting. I think generally people tend to agree here that it is important for people at the front line to contribute to quantification and forecasting of their own needs. And this kind of informs discussions around, so how do you do this? You do it, when you're ordering or supplying health facilities, do you use a push approach where you have central levels determining how much facilities should get and pushing commodities to them, or should you have a pull approach, which is really bottom up, where facilities get to have some say into what they need and how much they need, and to have the capacity to do that. And then you have the procurement itself. So, the ordering, and again, here, there are several ways in which you can structure autonomy. You're thinking about decision rights there. And, one is, who to procure for. And what we see when we look at a couple of countries is that a lot of the times when you have a central medical store, then that decision is pretty much set. So facilities do not have a lot of say, and it's kind of understandable because you want to benefit from food procurement. But then you have countries that provide for the flexibility for facilities to have some local procurement from local suppliers. And the reason for that is that then it gets to give you the advantages of filling the gaps, in terms of timeliness and filling the gaps, in terms of, getting commodities that might not be in stock at the central level. So you have several decisions or decision rights, and you have several configurations across of that. And so really the question is, what is the right configuration, and what capacities do we need to provide to facilities so that they can be able to take those roles and responsibilities.
It's not as if we're starting with a blank slate. Like we already have experiences in different countries, whether it's in Kenya, pre-devolution, what kind of decision rights those facilities have, and indeed in West Africa, where and other countries have implemented the Bamako initiative and created revolving funds and things like that. So with that in mind, I want to switch, Javier, to you. If you can hear us, just nod your head if you can hear me.
Yes.
Perfect, okay. And we can hear you too, which is perfect. So, you've worked extensively across many countries, including in West Africa. And so I was wondering if you could set aside sort of your USAID hat for a minute, not as a donor, but as a practitioner who's worked in the field. As we're thinking about this issue, what are some practical challenges that we can anticipate based on existing experience that you've seen in the field?
Yeah, thank you. Thanks for having me. And sorry I couldn't be with you in person. Can you hear me well?
Yes.
Okay, perfect. So I think there are a couple of advantages first that I want to highlight on having a decentralized procurement and autonomy at the facility level. One of them is that the facility, the service delivery point is really closer to the demand signals. So the staff there can react more rapidly and responsively to what they see with their patients coming and to the facility and what they're asking for and what their problems are. So the response time is much shorter, and so there is a high likelihood of reduction of stockouts, just being more responsive to the needs of the patients, both in terms of quantity, types of drugs, and timing. The second, however, the ultimate, I would say, demand signal responsiveness is when the patients are actually the one who are paying for the commodity. So when you are going away from a free system to a system where the patient is also your customer, that's where a lot of dynamics come in, and automatically there's an accountability system that comes in that is the most efficient, basically, because the patient will vote with his or her wallet, right? So if the performance is not acceptable at facility A, they will go to facility B where the performance is higher. But the second advantage of this model is actually to create an accountability system at the local level, because it's likely that the patient knows the service provider at the facility level that covers his or her area. And so you automatically have a dynamic where the facility staff can no longer blame or deflect responsibility for stockouts to the central level or to whatever other entity, because they are in charge of providing the facilities. But going back to your initial question on the challenges, the practical challenges, is basically what Prashant really distinguished. It is very unlikely that you can have at facility level the expertise required to set up contracts with a regional or national wholesaler, right? You're not going to have the negotiating skills at each facility to establish a contract with those entities whereby you can get the commodities that you need at a price that is affordable for your patients. As a facility, your volume or purchasing power is very, very low. So that's the first challenge. Other challenges are basically ensuring quality, making sure that the facility staff orders from quality suppliers for quality products, buying at an affordable price, meaning you want to make sure that there is equity for the patient, and you also want to make sure that there is I would say a removal of impunity. If there are shenanigans between facility staff and suppliers that jack up the price, you want to make sure that there are consequences to those violations. So the safeguards around that are, as Prashant said again, And in the order of the challenges that I mentioned, in terms of ordering is different for procurement. If the facility is in charge of ordering against a centrally negotiated existing contract, you have the best of both worlds, because you benefit from the aggregated demand at the national level. You don't have to negotiate your terms and conditions as a facility. You just buy into an existing contract, you order, and then you get your commodities at those terms and conditions. Other safeguards for the other issues are about, obviously, clear regulations, enforcement of these regulations in terms of quality, and the accountability system that locally that I described earlier. I hope this makes sense. It's three in the morning.
Absolutely. Thank you so much, Xavier. I hear both sort of the emphasis on bringing in the demand side, right, which is something that certainly in the financial community we talk a lot about. So giving clients a voice, ensuring that those signals, capabilities of the right. So great to hear you articulate the importance of that. But also very much in line with both what the Chancellor and what Edwin said, it's not a zero-sum game. We're not talking about moving all functions to the central level, or in this case, moving it all to the facility level, but coming up with a more nuanced mix that leverages the benefits of certain things being centralized and certain things being decentralized. So thanks so much for that. So Nutella, I wanted to now shift gears a little bit and hear from you from the global fund perspective, if you will, as a big funder, influential funder that has encouraged many countries to set up more centralized procurement mechanisms for priority, for commodities with priority diseases, as well as funding some DFF interventions in some countries. So I was curious to hear from you, is this kind of blended approach or a more nuanced approach, does that make sense? And where does it make sense? Where does it perhaps make less sense for the kinds of priorities that the Global Fund is advocating?
Okay, so excuse me, just to give a very short answer, I'm always for nuance and blended approaches, because when things are balanced, they always work. Now, for the global fund, a little bit on the procurement side, and then a little bit on the BFF, and then the nuances. So on the procurement side, we purchase commodities for 3 diseases, HIV, TB, and malaria. And there are some peculiarities with these diseases in the sense that, especially for ARVs, we have a few even global producers. So you can't buy them locally, you can't buy them in the free market, you have negotiated prices, and therefore we do pool procurement through our WAMBO system, or then there is a global drug facility, or there are UNICEF pool procurement tools, where we ourselves, when we provide the medications, we pool them internationally so that we have really a very good price. Or in the case of MDR-TB, there is really a very small market, and therefore you have to do it in a pooled way. Now, when then countries purchase themselves, they also do it in a pool procurement fashion. Sometimes they do procure through our internationally pooled mechanisms, but so there is not any local producers, and the medications, they are a little bit sophisticated. You have guidelines. So in this case, we do have a market shaping strategy that is very active. So in this case, it would make sense to procure it at the global level. But then there might be cases, especially for malaria, and especially when we do have local production, like for example in Ghana being one of the countries, where perhaps we could look a little bit and see what happens. Now, if we go to DFF, we have been increasingly using DFF and actually allocating directly global fund grant money to certain facilities. So it's happening now in the province in DRC. We had through the new funding request pilots in Tanzania and also Mali. However, we have used it basically to improve quality of services and to pay for community healthcare workers, exactly to improve the quality and to increase the demand. So there is the demand side there, because we do have cases when the medication commodities, they are in the facilities, but then either there is no demand for them or there is not any incentive from the healthcare providers to provide those. So we do have direct facility financing and results-based financing, both of them, to improve the quality. Now, having said that, given that we provide a whole range of medicines, we haven't. So actually, to respond to you, we haven't used it for commodity availability. But for example, there was an example of Ghana where they do produce anti-malarials in the country, when the government has indeed negotiated with the local producers a contract with the prices, and the facilities can go whenever they need, can go and get these medications from the producers, but or suppliers. But because the government never pays in time, they can't carry out this function, and we have seen stockouts. Now, if the facility had the money themselves, given the prices and everything, and they are produced locally, and the prices, have been negotiated, perhaps we will not have this stockout. So this is the nuance. And then also for HIV, for example, we do purchase also for opportunistic diseases. So these opportunistic diseases that are a little bit more in line with essential medicines list and whatever. So in those cases, perhaps this could be something that we could look at. But then the majority, the bulk of our purchases will be a full procurement, will be given through programs. And they actually know. So there is not that spontaneous person going to the facility. So, the programs, they have a list of people, they follow people that take medication for adherence and so on and so forth. But again, for the new, as we now expect the results from the DRC, and as we have more and more pilots and global fund money going to directly DFF, perhaps this is something that we should look at.
Thanks. And I think on that last point about nuance, it also seems like it's even in the centrally procured high priority commodities, bringing in some role for facilities for ordering or maintenance, etc., would not only assist now, but also build capacities that will be needed for the day that will arrive when Global Fund is not necessarily bankrolling all these functions, right? And so it seems like it's something that sets up for the future. Or as okay, not right now, but that's the trend, increasingly would start to provide our funding on budget. So then that would be the case, but actually we'll have to start now in some way or fashion for those systems to be in place in the near future. Perfect, thank you. So I'm very mindful of time, so I'm going to ask one final question and then open up for questions from the floor. And then I want to come back to you. As a researcher, we've looked at the evidence. At the end of the day, we can have a normative discussion about does it make sense to give the positions more autonomy, which rights should they have, etc. But it's an empirical matter. There isn't the detail. So I was curious from your experience, having looked at this in a range of countries, and especially in Kenya, do we see some evidence? I know the next session is going to be primarily focused on that, but just to give you a chance to set that up.
Thanks. So what is the evidence? There are multiple strong evidence. So One, we as part of a project, what is it that makes certain countries perform or have better performing primary healthcare systems? And we've looked at this across a range of countries in India, Africa, and Latin America. And what has emerged as a key driver of PHC performance and PHC efficiency is health facility autonomy. District and health facility autonomy, and within that autonomy of procurement alongside alongside the other functions. So there is some evidence that providing that level of flexibility at that level improves performance for PHC systems and health systems in general. There's some evidence for that. And we can see why there's evidence for that. One, it empowers facility managers. It empowers them to be able to problem solve. If they don't have that flexibility, they are likely to solve whatever procurement or availability problems that they're likely to have. And second, it improves accountability. You can't hold managers accountable for things over which they do not have control. So, those are really two key mechanisms through which it improves performance. But what we see in terms of evidence across, when we do literature reviews and when we look at what studies show out there is a mixed bag of outcomes. So certainly there's a lot of evidence out there that providing procurement autonomy to health facilities has certain positive advantages. One, the key positive advantage is just improving the availability of medicines. And there are several studies that have shown this. This nice study that was done in Uganda, for instance, that looked at a range of level of autonomy and a range of outcomes. And the findings was that facilities that have high level of autonomy, so the 90th percentile, compared to those that have low levels of autonomy, have improved availability of essential commodities, about 21% improvement. So there's definitely evidence that autonomy improves availability of commodities at the facility level. It also improves the timeliness of supply, because a lot of the time what sort of affects availability is timeliness. How fast do you get the supplies? To give an anecdotal conversation I had with someone in Kenya, just around the time when we had devolution and all this autonomy was removed from facilities all the way, to the county level. One of the, pharmacists mentioned that previously they could get what you call emergency procurement. So someone is on a table and they find a drug that's not available, so you have to procure as an emergency. They will get it within the day, and at that time, an emergency procurement will take a month. So it ceases to be an emergency because of all the bureaucracy that you have to go into just to procure. So timeliness of getting the procurement is quite important. The other thing is that it also improves responsiveness. And here we're talking about the alignment between what you're procuring and what the community actually needs. So, there's evidence that there's some improvement in terms of alignment between what's in stock and what people need. And there's also some evidence that it does improve quality of care. And the thing here is that whenever we think about decision rights, we have to know that decision rights are accompanied with certain structures. So when you talk about financial autonomy, for instance, if you give a facility financial autonomy, then inevitably they're going to start budgeting and planning. So they need structures for budgeting and planning. So likewise, when you give facilities procurement autonomy, then they're going to form structures for that. And parts of that are, what has been implemented a lot in countries, medicines and therapeutics committees, which don't just concern themselves about, what medicines to stock, but also how to use those medicines and so on. And so because of that, then they improve the rational use of drugs, they improve the quality of drugs and so on. And there's evidence, from India and from Afghanistan that shows that, autonomy at the hospital level can improve quality of care. But those are the positive advantages that, the positive effects of autonomy. There is also a lot of evidence of negative effects of autonomy. And a lot of that is really just around procurement inefficiencies. So this includes things like the procurement of substandard goods and services, where there isn't sufficient sort of regulation and control around who you're purchasing from or who you're allowing facilities to procure from. Then you start having issues around substandard procurement of medicines. You can start having issues around inflated pricing, so an increase in pricing because these facilities don't have the capacity to negotiate better prices, but also sometimes it's collusion between facilities and suppliers to be able to procure at inflated price, which is that the more flexibility you provide at the lower level, then you open the room for rent seeking and corruption and governance challenges and so on. And that again is something that has been has been shown in several contexts. And then there are also issues around, again, capacity for financial management. So you have facilities getting into debt and having pending bills, and that has a sort of a feedback loop that then starts reducing availability of medicines because supplies are stopped and so on. And so the real thing really is there's a mixed bag of evidence. It works in some contexts, it doesn't work in some contexts. And so what's really important is to think about, what is it that makes it work in certain contexts? What should we do? What configurations do we need to be able to enable those positive effects and to mitigate against the negative effects? And I think Prashant talked about some of this.
Thanks so much. So a more nuanced approach, more evidence on what the effects are. But then I think you've also added that it's not just about the effects being good or bad, but how do you get to those good effects? What are the enabling factors? You need the structures, the accountability mechanisms, the capacities at the facility level, which I think goes really well with Nutella, what you were saying. So we've, of course, had this conversation over here. I'd love to hear questions from the audience, any burning questions or comments. I see one hand that's there, and my colleague Felix will just introduce yourself and then proceed with the question.
Thank you. Yes, Professor Nod, I'm a researcher from the University and University of. Is this working? Thank you for the morning so far. I have two questions, necessarily at the facility level. Having worked a lot in Zambia, maybe start at the district level, because if you come up with the categories, we all know when we talk about the capacity of facilities to do this, very, very limited and very, very overstretched to start with. Is that maybe way to start, at the district level, where at least in the case of Zambia, that's where the autonomy is. Okay. Secondly, and maybe this is more provocative, what I hear is a lot about health systems, getting the system to work. And at least in the context of Zambia, where I have worked a lot, the main issue in the system, the main cost in the system is human resources. We're all sitting here, not all of us, but many of you up there are sitting there representing different donor agencies. Donor agencies tend to not pay for human resources, recurrent cost in the system. So how do we do this in a good way? When we have a situation where government spending, increasingly so, goes to pay the human resources in the system. And we're talking about all these things that we need to make work, which are completely dependent on the human resources in the system. And how can we get away from that thinking? And it would be lovely to hear, if we have any government representatives in here, to see the challenge of these sort of still siloed funding, which the lady from the Global Fund was alluding to. Thank you.
Let's take one more question.
Good morning, everyone. Anthony Gatia, not from a donor agency or from a government, work for the Clinical Health Access Initiative. Also, just to pick it up from where you say, HR is definitely one of the biggest constraints in this overall process, but the solutions do exist. Digitization. So each of the steps that we are unbundling in the whole process, say we are unbundling procurement, vendor selection, etc. Technology can help with that. So as governments are embracing more technology, the person at the facility is still one us, maybe two. And now you're telling them, please try and do your quantification and forecasting for snake bites, which rarely happen and happen there. So all these processes, as we unbundle and are being clear on, these are the areas, I think as governments are trying to get the use of technology, because for governments, technology is not just necessary, it's critical. They will never have enough staff. They will have to use the technology. So as we unbundle, I think technology is huge, but HR is still the biggest problem. A very smart comment.
Yeah. Thanks for appreciating the smartness of the comment. I wanted to confirm
Mine is a comment and not a question. And I'll relate it to the experience in Nigeria because DFF, Direct Facility Finance, resonates very much with us. About 3 years ago, they just started implementing what we call the Basic Healthcare Provision Fund, which is targeted as making quality essential health services available to all Nigerians. And in implementing this, we have two major gateways. That's what we are discussing here today. So we have the National Health Insurance Gateway that takes care of the demand side. So we will have people empowered to seek care under the cover of health insurance. And then we have the National Primary Health Care Development Agency Gateway that takes care of the supply side through direct facility financing. And what BACPF has done for Nigerian facilities is that it's been catalytic in that it makes the state, the sub-national level, to develop their own health insurance agencies. So we achieved decentralization from the centralized system that made health insurance coverage very low in Nigeria. So we had decentralization of health insurance agencies to the state level. We also achieved the states having their own primary health care boards or agencies that also ensures quality at the state level down to the facility level. And then we also have states being able to coordinate between these two agencies. So that is the catalytic aspect. We also have the additional aspect in that states are now being challenged to also contribute to the Basic Healthcare Provision Fund, because the original one was from the federal government and it's 1% of our constituted revenue fund from the national level. So states are supposed to provide under the vision of the law their own contribution. And then we have the transformational aspects.
So in the next segment, we're going to have a presentation about Nigeria.
Oh, okay.
And discussants are very familiar with all these reforms that you're talking about. So maybe we can come back to you for the remainder of your comment.
All right.
I think it will be much richer when it's
in
context.
All right. Thank you.
Anyone with a question? Yes.
Good morning, and thank you very much. Dr. Moy Daniel is my name. I'm the Presidential Advisor for Health in Kenya. Now, I think, very good presentation. Happy to see you, Himara and team. For me, I go to what you have alluded to. And what I ask myself is that with the facility, autonomy on commodities and they have their own money, two things that I wanted to hear about. One is much of the public commodities find their way the private sector. Of course, through inefficiencies, as Edwin has highlighted. So which options do we have to convert the private sector into an ally instead of them looking for options on how to swindle the public, commodities? They become an ally. So are there lessons that we can be able to learn on that? The second thing is, well, it is good to have facility autonomy. What is the role of, the key funders in this disjointed process, which they have created anyway in Africa, so to speak, in trying to look at a facility as an integrated system that is providing care to a household as a whole? And availability of commodities within that facility become important. So what options do we have? How do we gravitate towards having commodities availability, not only for some programs that are well funded, but also for the other, and also for a country like mine, which is moving towards looking at a household as the one that we want to be at the center of service delivery. So how do we capitalize on this discussion that you're having so that both, we have a full scale view of commodity availability? I could ask more, but
yes. Thank you. And we all have many more questions, but I'm aware of the time. And so I want to come back to our panelists and get their reflections on this. We have a question about why just facilities? Is that trying to go too far? Why not start with the districts? Then I think a couple of reflections about HRH. Why are we just talking about commodities when perhaps the bigger challenge is HRH? Then I want to, perhaps Xavier, you could tackle this question about public commodities, making it into the private sector. How do we make private sector providers an ally in the process? And then the final question, the first question about the sort of fragmentation caused principally by funders. So Nirtal, I'm looking at you, and how do we start addressing that? So big weighty questions for which we have inadequate amount of time, but we'll do our best. So let's start with you, Edwin, first on the question of why facilities are not.
So I'm pretty sure that, in the next session when Anne sits here, she will answer that question. And the reason is, so I started off by saying that you can't hold facilities accountable for things over which they do not have control. That's one. Second, if you have facilities and you have facility managers and you have frontline health providers, then you need to be able to empower them to problem solve at that level. Now, the example of Kenya, provides an answer to that question. We had a situation where we had substantial decentralization of, in the form of devolution that shifted substantial functions to the county level, which is equivalent of, districts, with substantial autonomy over procurement and so on, but then removed all that autonomy from facilities. And there were terrible effects to that. So that provides evidence that actually, there isn't so much difference between sub-national level and the national level if there's absolutely no decision space at the facility level, because the facility level is where service provision is happening, is where people are every day responding to challenges, is where people actually know what their needs are and so on. And so if you don't have autonomy at that level, then district level autonomy provides some flexibility, but it is absolutely not. And it is not an excuse to say that facilities do not have capacity. The reason districts have capacity is because that capacity has been developed. The reason national level have capacity is because systems have been intentional about developing the capacity at that level. And so if we agree that it improves performance for a facility to have those decision rights, then we must necessarily agree that we have to accompany that with the capacity that's required, which is HR, information systems, capacity to do procurement and quantification, and so on, rather than using capacity as an excuse.
Brilliant, thank you. So for those who questioned whether it should be at the facility level at all, some strong arguments for why it's not an either or. It's not about county versus facility, but you definitely need facility and so Xavier, if I could go to you next and put you on the spot in this question of how do we make allies out of the private sector and address this issue of commodities from the public sector making it into the private sector. Any thoughts on that?
Yeah, thank you. Can you hear me?
Yes, go ahead.
Okay, great. So really quickly on the last point, it takes two to tango, right? So if you have a corruptor, you have a corruptee and vice versa. And there's this triangle where you have people who are willing to get into this kind of practice. You have to have some sense of impunity, and you have to have the opportunity. So you have that triangle, and for this phenomenon to stop, you're going to have to break at least one of those, the sides of that triangle. And by the way, the appetite of donors for this kind of behavior is diminishing, I would say, and I think it's becoming urgent to pay attention to this phenomenon, because programs will start questioning their raison d'etre if a lot of donated commodities find their way into the private sector. But going back to the private sector versus public sector, I think it is less a question of an ally or more a question of a co-participant in the marketplace. Basically, the private sector eventually is called for basically catering to the population who can afford the services and the level of service provided by the private sector. And in most countries, there is a portion of the population, as the middle class is growing, that more and more accesses the private sector for that reason. Uganda is a good example where upward of 50% and some say up to 80% of health services are provided by the private sector. So basically, it's more like a market distribution whereby the public sector can focus their resources on a smaller cohort and smaller geography of customers, patients, those who are basically the poorest of the poor, and really enhance their service level to that cohort. And the private sector can basically cater to the people who can afford those services. And like I said earlier, those who can, they vote with their wallets and they will go to the best performing entities. Over to you.
Okay, thank you. And Nirtila, really quickly, how are you going to solve the fragmentation of resources issue?
So just to recap that these programs, HIV, TB, and malaria, they came into existence because actually the health system of the countries was not catering to these people, and therefore we needed separate arrangements. Now we have to think as well, especially the countries that I focus, that the three diseases they comprise burden of disease. You know, for example, in the northern Mozambique, if you go in a primary health care center, out of 10 visits, 9 are for malaria-related conditions. So now what we have seen is that there are no capacities in countries, and especially for procurement, there are no capacities, and we have seen this even when we have tried a little bit. We have seen this also in more developed countries, like for example Vietnam, where PEPFAR delegated the purchase of ARVs to the National Health Insurance, Social Health Insurance scheme there, and even with lots of training and capacity building, the scheme there failed to purchase these ARVs, even if they had the money from PEPFAR. So it's not only an issue of money, and therefore Global Fund had to go in an emergency purchase, you know, to purchase through our own channels so that these people are not out of ARVs. So the bottom line is that there is a lot of capacity that is needed to be built in countries, and capacities are not built within a day. I mean, even the case of Nigeria, BACPF, Nigeria is a country that I know, the problem there is, yes, they do have the funding. How much of the funding has been disbursed? Less than half, because there is not public financial management skills at the health center, you know, or even at the district level or at lower levels, you know, to absorb these funds. So before going directly to, you know, integrating everything, because integration is not an end, it's just a means. We have to make sure that those capacities are there, and it is something that as Global Fund we are doing. So we are investing directly in Nigeria, in the BACPF, in the upgrades and strengthening of skills of those primary healthcare centers. In Nigeria as well, the country submitted a proposal, and we are allocating directly Global Fund money for state health insurances to pay for enrollment of people living with HIV. So it is a process that has started, or the blending of finance, or the community healthcare workers, but it will take its own time. Yeah.
Okay, so speaking of time, we should wrap up this session. to answer the HRH question, we'll do that next time. So this time we focused on commodities, next time we'll talk about HRH. So with that, I want to thank our panelists. I want to thank Xavier in particular for waking up at 3 a.m.
No problem.
My colleague to take over for the next session.
Thank you very much, Nirmala, and all the speakers this morning. As Nirmala has said, my name is Anne Mutuba from TINCWA, and I'll be facilitating this second session. I think from the first session, it's clear that we've explored how autonomy and decision space at the health facility level influence the availability of medicines at the health facility. And what's clear is that there isn't, or there shouldn't be, a clear dichotomy of procurement functions at different levels, but that we should adopt a more nuanced approach that takes into account capacities at different levels of the health system, but also allows health facilities to be responsive to the needs of their local communities. So that has set the stage very well for this second session, where we'll be digging a little bit deeper and getting insights and evidence from the ground. We'll hear more from three great speakers from Nigeria, Tanzania, and Indonesia. We'll hear about how health financing reforms in these countries have affected or impacted the availability of supplies at health facility level. And so we had hoped to start this session after tea, but tea is not ready right now, or coffee. And so we'll have two presentations, and then we'll break for coffee, and then we'll come back into the last presentation. So please indulge me a little bit with that change. So without further ado, I'd like to introduce our speakers this morning. Our first speaker is Brittany Hagedorn. Brittany is a senior research scientist for the Institute of Disease Modeling, which is an embedded research team within the Bill and Melinda Gates Foundation. Her work focuses on primary healthcare systems with an emphasis on the implications of funding mechanisms and human resources for health. Brittany holds a Bachelor of Science degree in Systems Engineering and an MBA from Washington University in St. Louis. Our second speaker will be Peter Benyaruka. Peter is a senior health economist at Ifakara Health Institute in Dar es Salaam, Tanzania. He has extensive experience in health financing analysis and health system research, including monitoring and evaluation of various health financing reforms, such as results-based financing, direct facility financing, and health insurance reforms. Peter has a PhD in health economics from the University of Bergen in Norway. Our third speaker this morning will be Prastuti Sowendo. Prastuti, we also call Ibu Beki, is a senior advisor to the Minister of Health in Indonesia. She has previously worked as an academic at the School of Public Health and Administration and Health Policy at the University of Indonesia. Prastuti has an MPH and a PhD from UCLA. So we'll go right into our presentations. And after each presentation, I'll allow one or two clarifying questions, and we'll have much more time at the end of all the presentations to engage much more with our speakers. So please just keep your questions. So we'll start right off with Brittany. Welcome. Let's please have Brittany's presentation.
Hello, everybody. Pleasure to see all of you here. Brittany Hagedorn, I work for the Gates Foundation, and our team does a lot of secondary data analysis. So that's what you're going to see today. This is looking at a study that was done by the World Bank in Nigeria in 2015 to 2017. And my big caveat here is that any of the stories that I tell you about interpretation, right? I'm an analyst, I do research, but any interpretation of what are the implications, those are stories that I've gotten from World Bank colleagues, collaborators, people who were on the ground when the study was actually done, right? So I did the math, and then those stories are coming from other folks. This is the study that informed what our Nigerian friend was talking about, the HCPF. So this study was successful enough that this was a key piece of evidence in driving the formation of the BHCPF program in Nigeria. like I said, it was originally designed to look at results-based financing. There were two studies, so there were 3 states that were controlled states. You see those here. And then there were 2 arms to the intervention. One was direct facility financing, the other was performance-based financing. I'll show you both. PBF generally did better on most of the metrics, but they also got twice the amount of money, and they didn't do twice as well. So keep that in mind when you're looking at this, that when you see PBF outperforming, it's both due to potentially the incentives and also just the amount of cash that these facilities have. All of this data that I'm referencing is available publicly from the World Bank data portal, so you can go look at this out. And we're going to look at the surveys of the facility readiness at baseline and endline. Okay, so we're going to look at basically 3 measures. One is in stock, out of stock. There was a list of about 60 supplies that facilities were supposed to have on hand. Was it available on the day of the survey? The second metric is going to be how much. So the level of inventory, not just is it in stock, but how many do you have on the shelf, normalized by population. And then the third will be affordability. Affordability here is going to be measured by free. Is this product offered for free to users or not? We're going to use that as a proxy for various taxes. Okay, so starting out, this is looking at just your 59 supplies, everything from oxytocin to antibiotics to vitamin A that facilities are supposed to have on their shelves. In this case, higher is better. So if you were way up at the top, you had all 59 on your shelf on the day of the survey. No facilities had that. In green, you see the control facilities. So there is some small improvement going from a median of 13 to 16 over the course of those 2 years. This is good. We want primary healthcare to improve generally, but you don't see a lot of change here. In the intervention facilities, you see a substantial improvement, right? So the median at baseline is 12, DFF at endline is 26, PBF is 31. So remember, I just said CBF had double the money. We don't sort of see double the improvement. But so it's good, right? This is showing us that, in fact, the study did what it was supposed to do. It improved supply readiness. 2 things I will note. At the PBF level of funding, you actually see basically an elimination of these like no service providers, right? So if you look at the list of antibiotics, there's maybe 5 or 6. Some of those are interchangeable. Maybe it's okay if you don't have every single one on your shelf, but you should have at least some, right? If I don't have the basics, that means I don't have vitamin A. That's not really an acceptable PhD, right? Whereas maybe 15 or 16, maybe you're starting to get basic function. So PBF is basically eliminating that terrible performance PhD. The other thing that you're going to see up here at the top is that no facility is actually able to get to the full list, right? This is a market issue, right? So it actually doesn't matter how much money I give a facility. Maybe there's just not oxytocin to buy in Nasabella, right? So I think the takeaway, one of the things that we find is that it is about facilities having autonomy. It's about them having budget. It's about them having the training, like Edwin was talking about, the capacity to manage it. It's also about it actually existing, right? And this is the role where, like the central stores, we've talked about some of these sort of hybrid models. There needs to be a place to buy from in order to be able to achieve this sort of top level. Within that set of 60, did we just get lucky? Maybe malaria changed, but nothing happened with vaccines, right? So we can look at those subsets of drugs and supplies. So the top row there, the all, that's what we were just looking at, and then this is broken out by category. Did a difference in difference regression. What's important in the difference in difference regression is that interaction term, and is that a significant or not? And we see across most of these, indeed, it is significant at a pretty high level. The one thing that I will note is that vaccines and TB are not significant for this study. And that's maybe interesting if you stop and think about how those programs are run. They're donor driven generally, they're national programs. Those are things that maybe facilities can't or don't have to procure on their own. Whereas things like diagnostic kits are showing huge improvements, right? So in that last column, you see like 2.6 units of supplies, right, are on the shelf. That doesn't seem like a lot, but that's a 50% improvement because there's only 5 on the list, right? So facilities without any sort of explicit incentives are choosing to spend their money on these things up at the top of the list. And seeing pretty substantial increases in stock. If we look at this related to revenue, is it, when asked this question, right, is it about I'm in the study, or is it about have money, or some combination thereof? And the answer is it's both. But revenue is predictive. It's an important part of this regression. This is looking just at the end line because they didn't collect revenue at baseline, unfortunately. So we can't say anything causal here, but we can say that it's associated with improvements in stock on shelves. So it's not just about having money, but it's about having enough money to procure all the things that you need to have, right? So just to keep that in mind. I wish I had also included a slide about autonomy. There's some interesting questions in the study about, they asked the officer in charge, do you have the autonomy to actually procure resources? Can you allocate your budget, or does somebody else tell you how to spend it? And the more they answer yes to those questions, the higher these outcomes are, right? So you see those are significant predictors as well. Okay, so in addition to on stock or in stock or not, we also see increases in scope of products. And here I'm showing you free products. So what you see, so in this case, farther to the right means more free products offered. And you see this big increase, right? So we saw more products in stock, and more of those products are free. So it's not just that we're putting stuff on shelves and charging users, we're actually providing free services to those users. So, right, when you start to think about this, there's no financial incentive for a facility to say, hey, you know what? Let's spend this money on products and then not charge anybody for it. That seems like a good idea, right? This must be in response to perceived barriers to access, right? We don't have a way to directly quantify, is this a barrier to access, right? Is finance a problem for users? But the facilities must be thinking so, or else why would they do this, right? There's no other sort of general reason that they would choose to spend their money this way. We've stopped going forward. Okay. The other thing I want to just look at is supply levels. And here we're looking at vaccine. So most facilities had vaccines on the shelf at baseline. Most of them still had vaccines on the shelf at endline. That didn't really change. But the level of vaccine on the shelf did see increases. So on the top, you see control. On the bottom, you see intervention. All states are improving, right? There was a lot of investment in EPI in this time window. So nationally, a lot of things are getting better. That's great. Intervention facilities improved more. So it's not just that everybody was going up, but they went up along with the national average, and then they went further. So they have more stuff on the shelves. And there's this sort of consistency here, right? Which suggests that at some point, facilities have enough to meet demand, because there's not really any difference between the DFF and the PBF study arms, right? So at some point, they have enough to be able to manage their day-to-day variation in demand for vaccination. Vaccines are free to facilities at this time in Nigeria. So why would giving facilities money and autonomy to spend that money change the level of stuff, right? Because they can't be spending that money on vaccines because they don't buy vaccines, right? So what's happening behind the scenes here, we have the data on like, how many cold boxes do you have? How many refrigerators do you have? How often do you go to the LGA store for stuff? Facilities are spending this money on those last mile cold chain problems, and we see that reflected through stock levels, which is pretty exciting to see, right? Facilities, going back to this autonomy question, right? It's not just about providing them free stuff, it's about allowing them to solve problems for themselves. And then last, these are just a couple of other examples. This is looking at the stock level. So higher means, these are all facilities that had stuff on shelves. How many do you have on your shelf? And across the board, these are just a couple of examples. You see more stuff on shelf per capita across a range of products. This is looking at Adamawa. they have by far the largest sample size and also the most robust implementation. And so you see this clearest signal in that state. And that's what I have. That was a whirlwind tour. Hopefully, if you have any questions, happy to share lots more details about this. But I think the takeaway, right, is that it was about increasing in stock, it was increasing stock levels, and it was increasing availability for free, right? And so I think we need to, the takeaway for me is that we need to look at all of these different metrics, right? Just stockhouse is not sort of enough to understand the supply chain changes.
Thank you very much, Brittany, for that insightful presentation. We'll take perhaps one or two clarifying questions. So still hold your questions. We have much more time to engage our presenters this morning. Any, yeah, please go ahead. Could you get him a mic, please? Maybe could you introduce yourself, your organization?
Just on your last point, I was interested in the increased stock levels, and I was wondering if you also compared that potentially to increased expiration of vaccines or other medicines, and whether there was a look at wasted traits and whether there was maybe an overcompensation for stockouts, or whether there was a consequence of that.
Yeah, we don't have any data on that from this particular format for the survey, so unfortunately, I can't tell you about that.
Okay, we'll take one last question.
Thanks, Brittany. Ian Barton. So many of the questions I had out of Prashant's data, you answered. The 60 number, right? And what jumps out for me there is that actually failure of the frameworks? So is it central stockouts, is it supplier failure, or is it actually failure of the frameworks agreements in order to be able to be purchased in pool? Is there anything you're doing in terms of studying that, the upstream causes of that downstream impact?
Yeah, we can't see that in this data set because we don't have any information about what was happening upstream. The one thing would be that to note the study design, they didn't require the facility to purchase through a central store or anything. So they could go down the street to the pharmacy and buy a thermometer or whatever they needed. So if they're not purchasing, then there must not be anything available, right?
Great, thank you very much. In the interest of time, we'll move to our second speaker this morning. Peter Binyaruka will be giving us some insights on how various self-financing reforms impacting the availability of supplies in Tanzania. Please let's go to Peter's presentation. Great.
Okay, good morning. Thank you, Anne. So I'm going to share some insights or some evidence from Tanzania, where we had an opportunity to experience the implementation of both DFF and the RBF, on how these might have an association in terms of improving availability of commodities at the facility level. So basically, I think most of the things we have discussed, we know about
the interesting stuff.
Level, and also we know about the growing problem in terms of shortage of these commodities across facilities, especially in low-income countries, and how this has an implication in terms of out-of-pocket payments across household and being less affordable. But we do have a couple of models of financing mechanisms which have a potential to improve the availability of these commodities. And here we are looking about the DFF and the reserve-based financing, which we have the experience in the context. So taking the case of Tanzania, where this program has been implemented, the RBF program has been implemented across 9 regions in Tanzania, which was run from 2016 to 2021. And this incentivized 16 quantitative indicators, but also a group of quality indicators. The payment was on fee for service, being adjusted with quality score, which also takes into account some of the availability of commodities. The RBF also in Tanzania incentivized the health managers, the district and regional managers, who are also responsible for overseeing these facilities, And they also incentivize the medical store department in terms of supplying the medical commodities to improve the supply chain. In terms of the spending guideline for this RBF fund, 25% goes to staff as staff incentive, but also 75% of the remaining fund is for facility improvement. But we have to take into account that facility improvement, portion of that could be used for procurement of medical commodity, but also could be for other things, for example, innovations. The DFF was implemented countrywide from 2017 up to now. It's currently going on. But this DFF started with the Health Basket Fund, which is the fund from donors, development partners, which are put together and being earmarked for the health sector. The payment method is the capitation allocation formula, which adjusts for population, distance, service utilization, but also performance on some of the indicators like family planning, but also availability of medicines. In terms of spending guideline within the DFF, it dictates to use 33% of the DFF money specifically for procurement of medical commodities. So these actually in most cases are being spent to procure from the accredited prime vendors, which is the accredited private sector supplier who are supplying on behalf of the medical store department in case the central medical store department runs out of stock. So in terms of the evaluation, we do have 2-time period data collection at the facility level. So we have the facility survey, which was conducted at baseline in 2016 February, and the end survey was in 2020 after 4 years. Basically, we had 2 arms here, as you can see. So we have the RBF arm, which implements the RBF program, and that was, in the other region was Mara region, which was serving as a comparison site for the RBF evaluation. So we had the intervention side and the control side for the RBF intervention. But as you can see within the timeline, the DFF come in between, of which was rolled out countrywide. So we didn't have the control for the DFF evaluation. So what we can assess is just the before and after estimation, but we can't do the different estimation. So this is what happened. So in April 2016, the RBF started in Mwanza region, and then in 2017, the DFF started countrywide. So we share insights here from both sides in terms of mixed method approach. So quantitative estimate in terms of the availability of commodities across facilities, but also showing some insights qualitatively in terms of how key informants have been explaining it, especially in terms of how the mechanism of change has been happening in terms of pathway to those impacts. So the study sites, as I said, 2 regions, Mwanza and Mara region. The sample size, we had 75 primary healthcare facilities in each region, which in most cases are health centers and dispensaries, which are lower level facility in our country. And also we conducted 12 facility in charge index interviews. So the outcome measures here, we have availability, but also stock uptrend. So the availability here was measured in terms of being available during the survey, availability of a particular item being available during the survey, but the stock out rate was measured whether that item was out in the last 90 days, 3 months before prior to the survey. And we use an index of different items. So for drug, we had 34 drugs and vaccine items. For medical supplies, we had 13 items and 13 functional equipment, which we assessed. So we have drugs, supplies, but also equipment. So in terms of how we identified the identification strategy, as I said, for the DFF, because it was rolled out countrywide, we didn't have the control site. So whatever we are going to do is just the before and after estimation. But for the RBF effect, we did the difference in difference estimation because we have the control site, but also 2-time period estimation. And we use thematic content analysis for qualitative analysis. So this, the result specifically for the DFF effect. And as I say, this is just a before and after estimation. So you see the first panel is about the availability of commodity, and the second panel is about the stock out rate effect. So what we are seeing here, the before and after estimation, is that DFF has an effect in increasing the availability of medical commodities, but also reduction of stock out rate in both regions. You can see the first part, which is specific for the Mwanza region, which had both programs, the RBF and the DFF. You see in absolute term, there is a significant increase in availability and also stock average reduction. But if you compare that with the DFF arm specific, the other region which just has a DFF but not the Arabic program, we see the effect, there's an effect, but not strong as compared to what happened in the region which had both RBF and the DFF. So the combined effect is much stronger as compared to the DFF effect in the other region. For the RBF effect, what we are seeing is that the availability of drugs actually improved significantly due to the RBF. This is the difference in difference estimator. So the availability increased by 6.5 percentage point, but also the reduction of drug stock out also reduced by 6.4 percentage points. However, we didn't see any effect specifically on availability of medical supplies, but also availability of equipment. What are some insights in terms of mechanism of change of pathways? First, the facility need to improve quality of care, but also performance, taking into account that availability of commodity is a precondition for them to perform and improve quality. So it has that push in terms of them to ensure that they have commodity on stock, to ensure that they're performing, to get the bonus, but also to improve quality of care. The second thing is aligning with the spending guideline, which both programs had dictated to use this fund to cater for drug stockouts in those facilities, which also goes in hand with the financial autonomy in terms of spending. So we know that 3% of DFF money was allocated for procurement of commodities, but also 75% of the RBF fund was supposed to go for facility improvement, but also be used to procure commodities. The third is about incentivizing different or multiple agents within the system. For the RBF, we see that they have incentivized health managers as well, who are responsible over these facilities, but also they are responsible to provide the approval for procurement of commodities to prime vendors. And also the incentive to medical store department, which is quite critical because they also strengthen the supply chain of these commodities at the facility level. The last part is about presence of complementary health financing mechanisms. As we saw in our case, that there is a stronger combined effect of the DFF and RBF in that region which implemented both programs compared to a region which had just one program. So to conclude, DFF increased the availability of drugs, medical supplies, but also equipment, but stronger improvement in Mwanza region, a region which implemented both programs. The RBF program increased the availability of drug, but not having any effect on medical supplies, but also on equipment. But also we have to take into consideration that the 75% of RBF money was meant for facility improvement, of which part of that could be used for procurement of commodities. But unlike for the DFF, which has strict restriction in terms of having 33% for procurement of commodities. So you can see how that decision was made at the city level. So they are more likely to use the DFF money to procure commodities and they reserve the other fund for the RBF for other things for facility improvement. So in that case, given the difficulties in terms of the evaluation design, we might be underestimating the actual RBF effect because of that interaction effect on those facilities which also implemented the DFF. In terms of the mechanisms of pathways, as I said, there is a facility need to improve quality, alignment with the spending guideline, incentivizing other health system agents within the system, but also presence of complementary financing mechanisms. So generally, RBF and DFF can potentially increase the availability of commodities at the facility level. Thank you.
Let's proceed with the next presentation. Sorry about that. Matt, I thought you were Peter. Can you believe it? That's on a light note. So Peter is still held up outside having coffee. So let's just hold our questions. We'll proceed to the next presentation and then we can take the matter. So our next presenter is Pastuti, the presentation on Indonesia. Over to you.
There's a button on the, there's a button on the. Okay.
Am I very perspective? Thank you for the opportunity, and I will start with giving you the three key issues regarding the financing policy and impact of the availability for the commodities in Indonesia. First, I will start with a brief evaluation of the health financing systems for primary care in Indonesia, and second is how the supply side works. And then lastly is the challenge of the facility as facing under the financial economy. So this is just give you a glance, prior to 2000, we are facing very strong decentralization where all the health programs, deployments, manpowers, consumables are all regulated and controlled from the center. So basically it's a top-down approach. And in the year 2000 marked as the beginning of decentralization, and health sector is part of the sectors that is fully decentralized. Central government gave full authority to more than 500 districts to govern the health sector, which they have to plan and budget using respective general allocation funds. Even decentralization for health was more established. It was evidence that districts unable to strengthen their health function of the Puskesmas, which we call as primary care at the front line to reach communities, was significantly deteriorating. And health indicators worsening and poor public health activities, and which impacted on the immunization coverage and screening TB, communicable and non-communicable disease. Despite the mandates of 10% of the budget allocation, the local governments spend to other sectors, mostly to infrastructures, and thus leaving little impact on the health indicators. So in response to that, in 2010, special allocation funds was established from the central government to support the public health activities at the community level. We call it health operational budget. So this fund was directly transferred to the district health office to finance the public health activities such as MNCH, surveillance, communicable and non-communicable, including the empowered to buy consumables based on their local needs. Why the funds goes to the district health office? At that time, due to lack of capacity of planners and managers to support at the Puskesmas level, so the decision is to transfer the money to the district health office, and district health office has a key role in planning together with the Puskesmas, the primary health center, in terms of mini workshop and priorities, the activities. So under this mechanism, Puskesmas often cannot respond with local issues, as just addressed to our early presentation, because frequently we have to follow the manual decided by the district health office. So in response to that, in 2014, Indonesia, as you may aware, that we established single payers social health insurance, and we integrated several schemes into one, and now it's covered about 260 million people, covering about 90% of population. And this accelerated phenomenal progress in health access for so many. Payment providers mechanism to the primary care is using a simple capitation. In addition, they have non-capitation for certain diagnoses. For the capitation, 60%, minimum 60% for paid for the curative care, paid for the incentive for curative care for social health insurance patient, and maximum 40% is paid for procurement commodities. So with this, I think health facilities have the authority to buy commodities from capitation money, and mostly is for curative. One of the implications relevant to the social health insurance is largely due to incentive available at the front line. So health manpowers prefer to work curative work rather than public health activities. So health manpower prefer to work inside the buildings to serve curative social health insurance patient, and ignore or avoid the public health activities such as surveillance, promotive prevention communities. So in 2015, there is a policy to allow Puskesmas to become self-autonomy, meaning that they have flexibilities to manage and allocate their own resources directly under the accountable frameworks. This is known as DLUD, that's self-autonomy. Unfortunately, the capacity to manage the resources at the Puskesmas was still uneven, and that the regions, throughout the regions, which I will touch upon later. Lastly, in the 2023, the health operational budget was transferred directly from the district health office to the facilities, to the Puskesmas. And they increased the value and incentive also given for those who do the public health activities. So there is an incentive for them to catch up all the health indicators. So in this first slide, I give you a glance how the financing modalities for primary health care evolve. With direct facility financing, the government aims for Puskesmas, public-private health care to have quality spending, which they can optimize resources and have flexibilities in response to the health needs. The next slide just give you a glance that parallel to that, the government is having centrally negotiated in terms of drug lists. So there is a team who select the national formulary of drugs and set a standard price for that. As you know, that the drugs in Indonesia is quite high, relatively high, and varies across the regions. So that's why the national drug of a list comprised of both generic and generic drugs. It's cover around the national formulary of drugs cover around 1,075 lists, and then there is a national list comprised of vaccine, national programs, and basic vaccine, TB drugs, and others. And this list published in the e-catalog operated by National Procurement Drugs. Then each providers can acquire drugs through e-purchasing. The problem are once the health providers buy through e-purchasing, the distributors often cannot supply due to long bureaucracy and small margin. So distributors prefer to supply directly to health facilities, but they can also purchase the commodities outside the catalog. So we already implemented the blended approach to balance it. The next slide is just to conclude that in terms of financing, the government of Indonesia policy already implemented direct facility financing at the Puskesmas level, the public primary care. However, it still needs a capacity to properly execute the institutional arrangement of Puskesmas and the capacity of human resources are varies across the country. So we have 10,280 Puskesmas, as many as only 30% have self-autonomy status, meaning full financial capacity, autonomy to plan, use, and report the activities for the guidance. And these facilities actually can optimize the flexibility to directly procure consumable in response to the local needs. Unfortunately, all of these facilities have the capacity to quickly understand and respond to the community needs. And for the remaining 7,000 Puskesmas who have yet to achieve this autonomy status, there is even more constraint. Although the funds is transferred to the Puskesmas, but the DHO, the District Health Office, are still play a key role in allocating budget execution, doing the budget execution. So in theory, the funds of the autonomy should enable these health facilities to optimize resources, but the budget planning and financial autonomy has been designed well, but I think the ball falls on the budget execution, where obstacles to utilize the budget still remain. So I agree that investment in human resources capacity is also urgently needed at the final level. Thank you. I think that concludes my presentation, and I'm happy to listen to all your feedbacks and questions. Thank you.
Thank you very much. Dr. Pastucci, I think it's clearly seen how different varying levels of autonomy within the same country can affect supplies availability. At this point, I'd like to take one to clarifying questions for Pastucci. I understand there might be some questions online. No? Okay, great. And then we'll also have 2 questions for Peter as well. So if you could just pose there. Any questions for? Yes. So we take these 2 questions. We still have some more time.
Thank you. Thank you for the presentation.
Please go ahead.
Thank you for the presentation, Becky. Just one clarifying question. My name is Chuckles-Garrett from Management Sciences for Health. Just wondering why so few facilities have BLUD status. What have been some of the barriers to increasing the number of BLUD facilities? Thanks.
Will you take another one and then you can respond to them? There's another hand there. Yes.
Good morning, everyone. Dr. Simeon Onyechi from Anambra State Health Insurance Agency, Nigeria. My question is actually for clarification from Dr. Peter. I wanted to know why we set at 90 days to assess stockouts under the availability of stocks assessment when we were reviewing both of them. Why 90 days? Just clarification there.
There were two clarifying questions earlier in the morning. Yes, you can take those and then. Yes.
Yes, thank you. This was also for Peter, maybe for the first presentation even. So in your presentation on Tanzania, you looked at the direct financing of facilities, but also RBF, and your conclusion is a combination was most effective. But I think with the first presentation and also evidence that we have seen in Zambia is that more money seems to matter. RBF not as clearly, how important it is. So can one land in another conclusion because what comes with RBF is also a whole lot of verification, right? And sometimes extremely costly, extremely time consuming, resource consuming. is it obvious that the conclusion should land in combination of different models, or maybe just, group actually simplicity, just give them more money?
One type of.
Okay, so another question for Peter, actually building on the same kind of thing. We heard in the Nigeria example, I think, that the PDF arm paid roughly double what the DFF arm paid. I wonder, is that a similar situation when you compare RDF and DFF combined in Tanzania? What's the difference in the amount of money that is available for those pieces?
First, you to respond fast, and then join us, and then we have.
Yeah, thank you for the question. The question is, if I'm not mistaken, is why the self-autonomy status was not without impacts, and what's really the obstacles. So we have 10,280 post-Christmas primary care, and it's only 30% is already have a status of self-autonomy. To be or to have a status of self-autonomy, you really have to fulfill the requirements, certain requirements. One of the requirements is human resources as well as financial management capacity. So you really have to have that kind of fulfill the criteria, and because once you become a self-autonomy status, then you can utilize the funds directly, and we just report after spending all the money. So with that, many of the bureaucracy can be cut and response immediately to the local needs. I also want to add the experience from the COVID. During the COVID, we have a budget shifting, and then we also have a budget not only shifting but also reclassification. And only those who already have a self-autonomy status can survive more and respond immediately to the local needs. Okay, they can buy all the commodities that needed for taking care for the surveillance, and then they also for the diagnostic kits and others. In for the non-self-autonomy status, just to change the budget, they have to have an agreement from the local government, which is takes a long time, and sometimes they are not really responsive. So in the policy, we are encouraging for more post-Christmas to have this self-autonomy status, but unfortunately, they have to fulfill certain requirements. Thank you.
Thank you, Dr. Pastucci, to join us in front of Peter. Yes.
Starting with the question about the decision to have 90 days criteria in terms of assessing the stock rates. So the idea is more about the context in Tanzania, because that comes from the process of ordering and delivering of commodity from the central and post part. So that is the process which is done on quarter basis. So they press their order, and then within a quarter they have to receive the medical commodities from the central medical store. So that was the decision why we decided to keep the 3 months interval each the quarter. The other question was about the two programs, the DFF and the RPS. Of course, it's not the matter of saying which one is better than the other, but I think the idea is how can we borrow from both modalities? We know the issue about the cost implications, especially for the RPS, the cost escalation in terms of the process which are being undertaken, especially around verification, which is quite intensive, and the costs quite expensive in terms of doing the verification because you can't pay RPF money before doing any verification. So you have to do that on quarterly basis, but also you have to do, of course, all facilities. It's quite expensive. But there are some elements which are quite important within the RPF, which could be borrowed to the DFF, especially for DFF, which involves source of fund, which could be quite substantial to the frontline providers. For example, in our context, the S-Basket Fund is quite promising as compared to RPF, which just started recently. Because with the S-Basket Fund in Tanzania, we started that agreement runs from 1990s until now. So it's quite reliable source of fund. It's quite crucial in terms of providing fund cooperation as frontline providers. So borrowing some ideas from the RPF to strengthen the DFF is quite critical. And in our context, as some of you might know, the DFF, it takes into consideration some performance elements within the payment program, which is quite different from other DFF in other sections. So that borrow some ideas from the RPF. The other question was about the size of these funds. Yeah, we had another analysis which we are looking in terms of these funds going to these facilities from the two modalities. On average, the RBF fund is quite huge as compared to the DFF on the annual average of payment across these facilities. And of course, the payment modality are quite different because for the DFF, they budget annually, but they get the disbursement that is done biannually, so twice within a year. But for the RBF, they do pay on a quarterly basis. So if you have to get that across 4 quarters, it's quite substantial if you compare with the DFF money.
There were 2 questions comparing the 2 experiences. I just want to clarify the presentation I was talking specifically about supplies, and you don't see a huge difference between RBF and DFF in that outcome, but the PBF arm did see substantially better improvements in certain outcomes. So I don't want to have anybody take away that like RBF isn't valuable for driving certain outcomes. It just wasn't supplies. So that's a little bit.
Thank you. At this point, I'd like us to have our 2 discussants. We have 2 discussants before we go into the Q&A session. So still hold your questions. We have some time for that. Our first discussant is Fatima Mustafa. Fatima is a health specialist with a health, nutrition, and population global practice at the World Bank Group, working on the nexus between public finance and health. We also have Ishani Kanpal. Ishani is a senior fellow at the Center for Global Development. And prior to this, she was a senior economist in the Development Research Group of the World Bank. So we'll start with Ishani and then move to Fatima, who will be joining us online. So this will be brief reflections on the presentations that we've had today. Ishani.
Thank you, everyone. Thank you for the introduction, and thanks for these fantastic presentations and the discussion earlier today. What I'm actually going to try and do is do a fairly sort of step back and big picture overview, touching upon a lot of the themes that have been discussed in both the morning session and these 2 presentations. And I'm going to draw upon some work that I did when, as I mentioned, I was in the World Bank, the research department, which is summarized in this report. I have 3 hard copies here for those of you who might want to add to your luggage going home. We're also doing a session where we'll do an in-depth dive on this on Monday at 8:30, 8:45 in the morning. So join us if this is something that piques your interest. So we talked a fair bit about things like DFF versus PDF, quality of care, demand side interventions, and HRH. There's a question that we didn't answer. So these are some things that I'd love to bring to bear this report, which was co-led with David DeWalt and Renee Flagstaff and a large number of people. So I'm not going to present the whole report here, but I do want to talk about a couple of things. So just to make sure we're on the same page, let's define some terms clearly. What is PDF and what is DFF? So in this report, we draw upon a very rich World Bank database of about 30 impact evaluations, which all leveraged evidence from PDF pilots. In 5 of these instances, there were concurrent DFF arms within those trials, randomly allocated DFF arms that allows us to really get into that difference between PDF and DFF. The really great thing about the way that these arms were developed is that the PDF projects, their umbrella projects, they all effectively nested DFF. So they all had the same operating budgets and autonomy, transparency and accountability reform, and community engagement components. The difference was that in PDF, there was this additional performance pay component. Now, there was this question about different budgets earlier. In Nigeria, so I'm actually, I was the person on the World Bank side that led the study that Brittany's presentation builds upon. That study is published in BMC Medicine. You can find it open access on my website. In Nigeria, the fact that twice as much was disbursed in the PDF arm was by design. The government wanted the facilities to receive the same amount of money, and then in addition to receive money for performance pay. The other country where we have this 2-to-1 PDF to DFF budget envelope in our sample is Zambia, and I'll talk about the results in a second. In Zambia, there was a question of absorptive capacity. The DFF facilities just could not absorb as much money, so they ended up disbursing half as much as the PDF facilities. Okay. So just on quality of care, one thing I want to show here very quickly is when you look at differences in coverage here for antenatal care on the horizontal axis, pointer here on the horizontal axis versus in effective coverage or measures of quality. There's a big gap, even in a subset of 5 sub-Saharan African countries, and we focus a lot in the book. They're all sort of in terms of simple coverage, close to between 85 and close to 100%. But in terms of quality, we see everything from about 85, 87% coverage all the way down to only about 20% coverage. So the problems of quality are really sad. And they do, in fact, with good reason, drive a lot of demand for PDF. But for and if this is of interest, I see people taking out your phones, come to the Monday session. We'll go into detail here, but I'm just going to run through some of the stuff we're doing in the book here to give you to tease your appetite. It's really important if you're trying to understand, or if you're trying to improve quality, to understand what constrains quality, and to not assume that it's health worker effort. Health worker effort, Edwin had this fantastic little quote, thing that he said that I'm quoting, which is, you can't hold facilities accountable for things over which they don't have control. You can flip it on its head and say, don't pay health workers for things that are not in their locus of control, and then expect quality to improve magically. So we look at structural quality gaps and we look at underuse capacity. And this is data that Brittany also called upon from Nigeria and green, but also Republic of Congo, DRC, Central African Republic, and Cameroon, for basic equipment and supplies, consumables needed for antenatal care, which all PHCs in our sample are supposed to provide and do provide routinely. None of them are fully provisioned in any of these countries with the basics that are required to provide, what the WHO would call a complete antenatal care visit. This is a subset here of the structural capacity needed. In the book, you can see the full snapshot. And those structural capacity gaps are actually larger than the gaps for underused capacity, which is, capacity that's been purchased, where there's the structural capacity available, where there's the knowledge available, assessed using health worker vignettes, and yet we see an underperformance. So that is that's the component of quality that should be malleable to performance pay. That is what's in the health workers' locus of control. That actually only explains about 30% of the shortfall that we observe in quality. Everything else is primarily structural quality. So that raises the question, why performance pay? Why is that how we want to improve quality of care? So now going to what we find in terms of the results, we look at business as usual. I'm not really going to go into that very much, except to say that there are impacts relative to business as usual. I'll come back to HRH in a couple of slides, but comparing DFF and PDF, and before that, comparing vouchers and conditional cash transfers on the demand side, because Nortilla brought up this issue of the demand side being a salient barrier. We actually find that cash transfers and vouchers in many settings, and this evidence is really from around the world, as you see here, using a meta-analysis. PDF underperforms relative to vouchers and CCTs. We don't have a whole lot of evidence in DFF from around the world. The geographic scope is much more limited. But where we do, the results are very similar to that of PDF. You know, one indicator, including in Nigeria, which PDF consistently increases, is institutional deliveries. Even for that, PDF is outperformed by vouchers and cash transfer programs, and the difference is often significant. So again, you know, why PDF? So now comparing those 5 countries, Cameroon, Nigeria, Rwanda, Zambia, and Zimbabwe, which had a randomly allocated DFF are nested within the PDF trial. Here are the results on outcomes, looking at measures of coverage and effective coverage. So this is a forest plot. This is plotting on the horizontal, the vertical axis here, the different outcomes we look at, again, measures of coverage and effective coverage. And on the horizontal axis is the treatment effect. In general, we would hope to see improvements. The only place where we see a relative improvement of PDF over DFF, and even that, you know, is primarily driven by a shift. Here. Is institutional deliveries again, and that's primarily driven in Nigeria and in Zambia by a shift in where the women are giving birth. It's not a pure increase. Some of it is just women who are giving birth in the private sector returning to the public sector when the public sector improves in quality. Okay, so let me now go back to the HRH results. Something that a lot of people have written about, there's been a very widely cited op-ed in BMJ Global Health that raises questions about the effect of PDF on health worker motivation and satisfaction. What we did was take from this same database of evaluations all that we can find about HRH and looked at the impacts of PDF on health worker motivation and satisfaction. The one thing to note is that all the end-line data are from soon after the end of the trial. So these results might be different, you know, long further down the road, but at least within about a year of the end of the trial, there are no demotivating effects of PDF. So the big fear, the theoretical fear is, or concern, is that PDF crowds out intrinsic motivation, replaces it with extrinsic motivation, and when the trial ends and that extrinsic motivation, the additional money goes away, you're left with a demotivated worker force. We don't see any evidence of that, right? So that is a concern that we can set aside. Everything else I've shown you, I think, raises many other questions about why you would want PDF in the first place, right? Okay, so just to sort of give you the big picture on where we end up in this report, you know, the evidence we find suggests that financial incentives, whether it's on the demand side or the supply side, so whether it's cash transfer to vouchers or it's PDF or DFF, can in fact increase service utilization, maybe some measures of quality, specifically structural quality, but these impacts are small and they leave a lot of room for improvement, including the impacts that we assessed in DFF in the pooled analysis. These are settings, you know, where effective coverage in particular is very low, and we're seeing very, very modest gains at the end of the day. And so in under-resourced centralized health systems, which, you know, feeds in very directly to some of the topics we've been talking about today, is centralization. Performance pay yields very modest additional gains beyond something like DFF. And then, of course, you know, it's important to remember in terms of operational implications that DFF is a simpler much simpler intervention than KBF. So there was again a question about verification. In Nigeria, we estimated that 2/3 of project administrative costs were attributed, and here's that site, to verification. Verification is not only expensive, but it also creates the opportunities for collusion, which you don't again have to worry about with a simpler mechanism like DFF. And the last thing to keep in mind about DFF is that it's not about sending money to the front lines without any accountability, right? You can build in accountability into DFF. So donors really like DFF because of the results link. And I would just like to remind everyone that DFF can have and does have intrinsic results links in it as well. And you can further build on that. So my colleague Moritz Kiaki, for example, is doing a really fascinating mobile money pilot in Zambia in rural health facilities, which allows the government to track how funds are being dispersed. So with that, I think the takeaway here is what I'll end with, which is that performance pay PDF is a very complex intervention, which can be really difficult to scale, requires a lot of absorptive capacity, requires a tremendous amount of implementation fidelity. And so to take results from one pilot, which had an effect on a subset of indicators, and to expect magic somewhere else, maybe not so much. All right, thanks.
Thank you very much, Shani. I think you clearly painted the picture that the impact of financial incentives vary significantly based on numerous factors. At this point, I'd like us to hear from our second discussant who is joining us virtually, Fatima Mustafa. Can you please get Fatima online?
Yes, good morning, colleagues. Can you hear me? Can you hear me okay?
Go ahead.
Yes, good morning. Apologies, I couldn't join you in person today. Thank you for interesting conversation and quite interactive session. I would like to touch on few points as presented by the earlier presenters in this second session and share the implementation experience for Nigeria. I think one thing we should reflect is where did we start from when RBF was introduced in Nigeria early 2020. I think we should reflect and bring ourselves back to where the health facilities were prior to the introduction of the performance-based financing reform. The baseline across different indicators, service delivery indicators were abhorrent. We had, although there was improvement in say skilled birth attendance and proportion of children under immunized over a period of time, most states started at the baseline figure of about 20%. The improvement was in from 20 to 47, and in some cases, 68% over time. Another thing to point out is
we can take one round of questions for any of our panelists or discussants. So we have a hand right there and another one here. Okay, so we'll take those four. Plus you, yes. Okay.
All right, good morning again, and this time I have a question. My name is Bolanle, and I work for the USAID funded local system sustainability project in Nigeria, worked by Apt Associates. So my first question is about the Nigerian case study, ENSHAPE, where you discussed about the result-based performance and the direct assisted financing. And it's clear that, as you clarified earlier, there's some differences and all of that. So for the result-based financing, you said that there was some flexibility in how they produce the funds. So my question is, it was obvious that providing commodity alone will not solve the problem, or having resources to buy commodity because of the autonomy. So do you have anything in your data from your analysis that showed that the actual improvements or more results for facilities that had result-based financing because we're able to solve some other challenges? We're not directly related to just having medicines or money to buy medicines. You have data that will support that model, because what we often see is that having a particular intervention alone does not solve all the challenges. You also have to remove some other barriers that you have to performance. And second, related to that is your choice of facilities. how were those facilities selected? The ones used for airship. They are the same facilities from ACPF in Nigeria right now. And what we often say is that many of the facilities have been used over and over again or supported over and over again for different interventions. They just stand out. It's easy to pick them and use them for subsequent interventions. So you don't know why you have some, this result, this replicable, for example, across the whole country, they apply the same strategy. And thirdly, you mentioned, I think, that you had trainings, for those ancient facilities. Did you train the facilities? And if you train them, were there trainings on facility and financial management, which I think also contribute to their performance, and not to use their funds, their autonomy to buy drugs? And did you train them on logistic management, like PSM, procurement and supply chain? What specific trainings did you do? So we are, as we are implementing BACPF, and also, focus a lot on these kinds of interventions over and over again. Thank you.
So we could have another question on this side. Yes.
Yeah, so I'm Dominic Coman now. Yeah, I think thanks. The World Bank, there is a question. It's a great packaging of the evidence that in our country, I think I actually did it. So I was just wondering whether in the evidence that you've been working on, there's the effect of the community component. Whether that's been evaluated, because that's something that we're thinking that in the main difference, obviously, from the Mao design, we've thought that there's not much in DFF and I think this results kind of but I think the angle we're trying to explore the extent to which if we transform the community structures to provide oversight akin to facility boards. I think it's something I guess with Molly's there also like that. So the extent to which that can squeeze some of the purported results that we see there, which are obviously connected with the money also. The money, enhanced supervision, expensive monitoring. If we can transfer that to community structures, how much gain we could, and then build more of the investment in the grant side rather than the monitoring. I don't know.
So we let's keep our question, please.
Thank you. So my name is Professor Koladi from Health Systems Council Limited, Nigeria. Just two questions. The Tanzanian person, in your presentation, there was a lot around incentivizing the health manager, the MSD. Has there been a way you've been able to track how this trickle down to the actual clinicians and the other non-clinicians at the facility to help in the performance at for each of the facilities? And the concern around how do you ensure the sustainability of this incentivization? Because like I've rightly stated, even from the last presentation, PBF seems to be quite expensive. Then my other question is to Indonesia. I'm sorry, I'm not used to pronounce your name. Is there a governance deliberate effort towards the non-BLE who are more than the BLE at this point in time, towards meeting those criteria that have been set for the BLEs that will make those things, particularly around the financial management, the capacity things. For the BLEs, how do you ensure that there's still that reporting, the bottom-up reporting, in ensuring that is in place? Thank you.
Okay, thank you. My name is Martin Oranje. I work for Coordinate, this international NGO, and also for the World Health Organization as a consultant. Well, thanks for all the presenters. This was very interesting. I have a question about what exactly you mean when you talk about the difference between EBF, RBF on the one hand and DFF on the other hand. Because my sense is from the presentations that you see, which I greatly enjoyed, that the differences are maybe not as large as we like to present them. I like the observation by Peter that RBF and DFF in one way or another should be complementary or can be complementary. In the sense that if I see from the presentation of people who say that even DFF, the payment is also based on utility performance and on health service utilization. Also from the Indonesia case, we heard that I think considering also bringing a link or some sort of incentives related to public health indicators. And also from the last presentation by Shan, you said some link to results or some link to performance is also a DFF would be desirable. So to what extent, that's my question to the panelists, to the presenters, are we talking about a real difference, in categories? Are they really different things, or are they more similar than maybe the implied thing? And is it more a matter of how happy are you in one more than the other? Because there will always, I guess, be some sort of verification.
Thank you. I think there are questions for just about all our presenters. We start with Peter.
Okay, thank you. Maybe I start with the question which was asked last side about incentivizing different health system margins. I think that the idea is coming from background. But also we had incentive for community workers for them to escort women to the facility, but also to do some home-based visits to stimulate the demand side in terms of accessing healthcare facilities. The other question was about the combination of the two programs of the second. The RBF and DFF. Of course, it's quite tricky to disentangle the two. But from my own perspective, I think it's more about borrowing the ideas from each of the two in terms of the strengthening the system. That has been the basic idea actually in Tanzania, because introducing the DFF, which started with the Health Basket Fund, which has been there for quite some time, but now to push further the fund to the frontline provider. So the idea was to borrow some elements, the good elements from the RBF, to be integrated within the DFF. That's why you see in Tanzania, the Health Basket, the DFF takes into consideration some performance elements within the allocation formula. So the idea was to borrow some good elements within the RBF to the DFF. Because with the RBF per se, it's quite complex in terms of implementation, and it consumes a lot of resources. But we can borrow some good ideas to the DFF, which might sound sustainable somehow going forward.
So thanks for the questions. There was this question about community engagement. So we can answer that first. We have not separately evaluated community engagement. The design of the pilots in question does not allow for us to disentangle community engagement, but there is a really well done study by Jakob Svensson, by Martina Bjorkman and Jakob Svensson that looks at citizen scorecards in Uganda and finds very large effects of that component. And actually, that's one of the reasons that study is one of the reasons that that component was included across the board in all of the pilots that we studied. So you're definitely onto something there. Brittany, I don't know if you want me to take the Nigeria facility selection question. So it's a great question. For the pilot, the government selected the states based on measures of development for treatment, and then we selected comparable states for control observations. The facilities were randomly selected. I do want to note that this is a very large, even though it was a pilot, we covered about 9 million households in the pilot itself, with three treatment states. One of the things we found in the original study is that where there were the largest improvements in quality were in facilities that were that had the most room for improvement. In terms of structural capacity, the result was sort of flipped on its head, where the facilities that had basic structure were the ones that improved more as a result. That's why. So that, you know, indirectly, I think answers your question about why it might be worth investing in the same facilities, which is not to say that the rest of the facilities should be ignored, but there is a lot to be said about sustaining investments. And then finally, just very quickly to touch upon this question about what the difference is between PBF and DFF. You know, I think a lot of people sort of that belong to the Church of RBF would say that everything is RBF, and I think that's not incorrect. You know, I think we are all in agreement on the need for flexible funds at the front lines, but recognizing that there are multiple constraints faced by the front lines, you know, being sort of humble in what we can expect out of those funds by themselves. And we all agree, you know, that transparency and accountability are the way forward. No one's really, you know, pushing for sort of inclusion.
Yeah, thank you for your question for the information. I think the government, the central government actually pushed the statement that primary healthcare to self-autonomy in this hospital, but there is a team doing the assessment that I think is for that. But the fiscal capacity on one district to the others is different. And actually the district health office are the one who not ready for the delegates, you know, because that's in those districts that have a low fiscal capacity rely from the health company and subsidize to the others. Once you have self-autonomy, then you have the flexibility and fully use the money for the operations of health, you know. So that's one of the big issues. The second issue is that the capacity of the human resources for the financial management, accounting, and then information is also one of the essential criteria to be there. So financial accountability becomes the key for having the self-autonomous status. Thank you.
Okay, so a couple of questions there. There was a first question about did the PBF arm affect other barriers other than supplies? And you're testing my memory a little bit. I believe that family planning was one subset of supplies and services that was specifically PBF was significant in predicting. But for the most part, no, there's not a lot of barriers that it changed. In addition to the revenue and sort of the study arm being in the study, right, matters a lot. If you see like control facilities that had a lot of revenue, don't see the same sort of performance as any of the facilities that have the same level of revenue, right? So in addition to the financing, I think it's important to emphasize that there was budget like support and like how do you develop a budget, there was autonomy, there was a lot of the capacity building that Edwin was talking about earlier that went into the study, community engagement. And so when we think about the impact, like that has a huge value in the study in addition to the financing that we see a positive effect for. The other thing I'll mention, I guess, to this question of the difference between DFF and RBF is that when we look at measures like worker productivity or other aspects of readiness, there's some questions in there about how often does your external supervisor actually come by, right? And do you feel like you can have meaningful conversations? Is that feedback actually useful? Are the guidelines useful? And you see things like when you're officer in charge, their primary language is Hausa, and the guidelines are written in English, then they say, no, the guidelines aren't useful, right? Well, this makes sense, right? And this is part of the accountability, which is when your supervisor shows up frequently and you can have meaningful conversations and they give you good guidelines. This is where the accountability comes in, even in DFF. It's not unaccountable money, it's well supported and trained money, and that I think there's probably a smaller gap there than we would otherwise. Ishani, correct me if I said anything helpful.
I don't remember if the MCTR difference was significant, but yeah.
Thank you all. Let's try and see if we'll get Fatima online. Fatima, please go ahead. This is your last chance.
Now she's not speaking. Before she was.
She's muted.
Fatima is muted.
Okay.
Hello, can you hear me?
Great. Okay, please go ahead, Fatima.
Okay, I would first like to thank the presenters for touching on different aspects of the experience in DFF and PBF. I think one thing I would like us to reflect on is what were the objectives of the various projects or programs from the onset. I would speak of Nigeria experience first, and then try and touch on the similarities with the two other countries. I think the objective for the NSHIP program was to improve access to maternal and child health services. That set the stone for whatever was to be expected as the outcome of the project. Two is that we should reflect on where all these countries or states started from. That is the baseline. I think if you look at the indicators presented by Brittany, you would see that the baseline was abysmal from the very onset, but there was significant improvement over time at the end of the project. Third is that for NSHIP in Nigeria, the design of the program and the two intervention arms were relatively similar. One is that the autonomy was almost equal for both DFF and PBF facilities. However, even though the program was designed such that PBF facilities or local governments were to receive performance incentive, that's 50% of that, as mentioned by Ishani, the DFF arm also had the leverage to incentivize their contracted healthcare workers. Contracted healthcare workers in the sense that they had the autonomy to have ad hoc staff to support the facility in delivering both quantitative and quality measures of health services. Lastly, I would like to say that the fact that the objective of the program is not just to increase the supply of commodities in the facility, we cannot talk of that without looking at the whole system and whole indicators, both quality and quantity. There were significant improvements, there were limitations. In the case of Nigeria, procurement of commodities were centralized, and they were also kind of managed such that all facilities were expected to procure from central stores owned by the state government or the federal government. So wherever there were limitations in the commodity in the health facilities, it's not limited to the efforts that were made by healthcare workers or facility managers, but the system overall. If there are no commodities or drugs in the central stores, then these facilities have limited autonomy or option to go and procure from the private sector. However, though I mentioned that there were exemptions given in some settings where the central stores were not able to respond adequately, or that the facilities were twice removed in terms of geographical access to government-owned central stores. In such instances, facilities were allowed to procure their drugs or medical consumables from the private entity, but that's limited facilities or local governments overall. Lastly, I would like to say that I think the main objective of the PBF program in Nigeria was to improve service delivery at the health facility level, to remove barriers such as leakage in access to funds for facilities to deliver the adequate service that is required for their communities. In that sense, we have seen significant improvement. And as Ishani mentioned earlier, that PBF, although PBF was twice as expensive as DFF, in contexts such as Nigeria, I think the reflection should actually be what was the improvement from ground zero to the time when the project was closed. So for us, the lesson here is that if there are avenues or tools to ensure that health facilities have the needed funding to deliver services, and there is adequate supervision to ensure adherence to quality standard, then that should be the approach that should be started from, and then improvement can be incremental over time. Thank you.
Thank you very much, Fatima. People are laughing and saying that, you know, put there Fatima a must, you know, you had to be from you. That's just you know, short for her name. But just like all great discussions, we're actually running out of time. Unfortunately, we won't have time for another round of questions. But please feel free to engage all our presenters and discussants after the session. So I'd like to thank you, our presenters, very much, and our discussants. Thank you all. You are a fantastic audience, and Fatima as well for joining us virtually. Thank you very much. At this point, I'd like to hand over to Edwin, who will walk us through the final session.
Thank you, Anne and Tish, for that. So we've had a whole day of having a bit of a discussion in the morning, and getting deep into country experiences in the mid-morning. So now we would like to have a bit of a reflection, really, as we wind up, a bit of a reflection around our research agenda and what this all means for us from a research perspective. And to do this, I'm going to have a discussion with Professor Kara Hanson, who's joining me at the front. You can have a seat anywhere. Many of us know Professor Kara Hanson, so she doesn't need an introduction, but she's a professor of health systems economics at the London School of Hygiene and Tropical Medicine, where she's also the dean in the Department of School of Public Health, and she also happens to be the president over here, so she's our boss here. Just so you know. And the idea for this session is to really just have a reflection. And Kara, you led the Lancet PhD Financing Commission. So the first reflection we'd like to hear from you is that one of the findings was around, autonomy of PHC facilities and what it means for PHC performance. Could you reflect a little bit on the finding and its implication relevant to what you've had today?
Very much, Evan. I should note that I'm the president-elect, so my job doesn't start till January. So I have no power yet at all. It's so nice to be here. I would just say, before answering your question, Evan, I think the idea of bringing communities together is so important. You hear these conversations in parallel about supply chains and logistics and about health financing, and it's so great to see these things come together. And so I want us to keep bringing that together. We're not just talking about DFF, we're talking about DFF as a means of improving commodities. So the Lancet Commission, so you're right, we did look at facility autonomy. Partly, we had some results from a survey that we did of provider payment arrangements, is where we started, wanting to know how our providers pay for PHC. But we added some questions as well about autonomy. And I think what was very clear was that in very few national health systems do facilities have much autonomy. I think there's two strands that we explored in the commission. One was just the importance of medicines for PHC, because out-of-pocket payments are still a huge share of PHC expenditure. So about half still of total PHC expenditure in both low-income countries and lower middle-income countries. And most of those out-of-pocket payments are for medicine. So cracking the question of how medicines are financed is absolutely essential for cracking the problem of out-of-pocket payments and reducing payment barriers to PHC. So that was one element we looked at. And the other was the relationship between provider payment and autonomy. And so changing the way you pay providers doesn't have any impact unless providers have the autonomy required to spend that money well. And the last bit of the piece was about getting money to the front line. So much of the problem of PHC financing is that there is so little resource. And it doesn't even, I think we know from years of studies of user fees, it doesn't take much money to make a difference, because so much of the resource at the PHC level is it's either staff, which is the great majority, or medicines, but some cash at the PHC level is really important to allow that problem solving at the PHC level, at the provider level. So the last thing I would say is that we were really disappointed in the evidence base on financing medicines. So you go into the medicines literature, there's endless treatises on those procurement issues, or the forecasting and the quantification and the procurement centrally or otherwise, but very little about the arrangements for financing for financing medicines in PHC. So we kind of found it as a bit of a gap, and think that it's an area for future research.
Thanks, Karen. That's actually a nice segue to the next question, which is really reflecting a little bit about our research agenda for facility autonomy linked to procurement and other forms of autonomy. So based on what we've had today, we've had quite a lot, and based on the work that you've done in the commission and so on, what do you see as the questions whose answers we don't know yet? So what is it that remains for us to know? And what do you think are the forms of research or types of research that could answer some of these questions? And what are the imperatives there? And as you're reflecting on that, we've seen some pieces of evidence presented already at the country level and cross-country synthesis by the bank and so on. So could you reflect about our research agenda?
Thank you. That's also a really interesting question. And I'm having a little bit of deja vu, because I remember making a similar observation around the evaluation of PBF and results-based financing. Because in a way, our starting question is, does it work? But what's the it, right? The it itself is so intrinsically heterogeneous, right? So if our it is direct facility financing and autonomy, the specific arrangements around how that is implemented in different settings are very varied.
That's the first point. And the second point is, where is it going to work? Well, that's going to be very dependent on a health system context. So how do we begin to characterize that health system context? So I was imagining, and then I guess one further layer of this is, how do we know that in one place? So how do we do a rigorous evaluation, not just of whether it works, but how and why it works, to moving to generating a whole evidence base across countries. So how do we synthesize this evidence when there's so much variation in the intervention itself? And so I was thinking about this first in a kind of a regression framework, saying, okay, so what I want to know, my why here, in this case of this morning, is commodity availability or medicines availability. And my X is DFS. On a whole bunch of countries, programs I want to regress Y on X. But I know right away that that impact of X is going to be modified by the health system. So there's another thing there, which is the health system and the interaction. And if I've got a ton of variation in my X and a ton of variation in the variable it's interacting with, I'm not going to get a very clear picture. I'm worried that I won't be able to pick out any signal from all that noise. So what does that mean then for evaluation and understanding? I think it means, first of all, we have to be really quite modest, and we have to start with really thick descriptions. Right? We need to describe these interventions in all of their detail. So when we're talking about autonomy, we're talking about autonomy over what decisions and under what constraints. Right? So we heard about decision-making subject to guidelines. Is it just guidelines, or is it specific guidelines and specific limits? So I think there's quite a lot of work to do in these evaluations of understanding all of the variation in the design of the intervention. And then the second is to think about, how do we characterize health systems to be able to look at how does this intervention work in a specific context. And so right away I was thinking, our classic kind of meta-analyses methods are going to be really tricky for that kind of those messy interventions in complicated contexts. So maybe we need to be thinking about a different approach. And then it's more about pattern recognition than clean identification of coefficients. So what combination of design features of the intervention are going to work in what combination of features of the health system? So then I was thinking, oh, maybe that's a data science problem. Maybe that's something that, maybe that pattern recognition needs, looking across really quite big data sets that are rich in the descriptions of those interventions in this health system context. Of course, that's going to be really data hungry. We know that data science is data hungry, and there aren't that many settings in which these programs are being implemented, and they're still also fairly new. So generating the data and then getting smart young people to work on new methods for pattern recognition would set us on an approach that's something different from the classical meta-analysis as a way of synthesizing experience across countries.
Thanks, Karen. And just to sort of take that a little bit, to go into it a little bit, and specifically reflecting on, I know you've already had the reflections on the Nigeria work and on the Tanzania work, and you've mentioned the issue of figuring out what is the intervention, what exactly is it, and it varies quite a bit. And people have asked questions about the counterfactual as well. What are you comparing it with? Do you want to reflect on that, and specifically for those two studies? Do you have any personal reflections on this?
I do think that we do worry endlessly about the difference between PBF and DFF, and I think it's really important to characterize them, because DFF can have elements of PBF, as Tina told us, and we've already commented this morning. So I think the really careful characterization of the intervention is one way out of that, because we're not trying to win a battle about which is best. We're trying to understand which variations of these arrangements are going to help improve health system performance in a particular setting. The one thing that actually, I'm not really answering your question, I'm still just thinking, but when Ishani was talking about the work that they did on this meta-analysis and synthesis across all these studies, the one thing she didn't highlight quite as much as she could have was the idea of understanding what the problem is before you set out to solve it. So again, so when you think about what is the counterfactual, both the counterfactual and the interventions themselves need to be dealing with a well-specified constraint, understanding what is the constraint. Is it a supply side constraint or a demand side constraint? Is it a supply side readiness or an effort and understanding or effort and incentive problem, or is it a skills-based problem? And understanding those, I think, is a really important element of designing the right intervention to study in the right place. So on the counterfactual, well, I think that's right. And I do think that some of the most interesting things that have come out of this vast program of World Bank research is the putting interventions on a fair comparison, right? So in some sense, what we want to know is what is the effect of the performance requirements on top of just giving them the money. And so getting the right counterfactual, I think, is terribly important. Otherwise, we're really not sure what we're observing in terms of difference is the result of the performance monitoring system or of the act of actually relaxing that financial constraint. So I think having the right counterfactual for these studies is actually really
Thanks, Cara. Thanks for all of that. We are now coming to the end of our session today. So coming to the end of our session today. So just to summarize some of what has come through the session, and starting with Cara's first point, really, from the Lancet Commission's work, that for PHC performance and for health system performance generally, it's really quite important that medicines are viable at the point where care is being provided. And what I hope, or what has come through today, is that financing and financing arrangements can be used as a lever to enable that. And one of the ways to do that is through direct facility financing, where you have financial autonomy, but also autonomy for certain aspects of procurement. So medicines, or rather essential commodities procurement, and so on. And the other thing that has hopefully come through the day is really the fact that when we talk about procurement autonomy or direct facility financing linked to procurement, it's really not a zero-sum game. Procurement is a complex process with several decision processes, and it's really about thinking about what are the decision rights across each of these functions, and what is the optimal mix or the optimal configuration for allocating some of these decision rights, across the entire system. So from the national system to the decentralized system and the facility system, rather than having a discussion about whether it should be centralized or it should be based at the facility level. And we've seen from the several studies that have been shared today that indeed, when you have procurement autonomy, you can have positive health outcomes. So you can enhance some of the health system goals. You've seen that in Nigeria, in Tanzania, in Indonesia, and the work that Ishani presented, which is across countries, synthesis across a range of countries, that direct facility financing and autonomy indeed can improve availability, timeliness, responsiveness, and sometimes quality with regards to availability of medicines and so on. But we also know that it is possible for procurement autonomy to result in unintended or negative outcomes. And we've talked about that. And so what's really important is to think about what is a configuration that works. How do we structure these arrangements so that they enhance the positive intended outcomes that you're interested in and mitigate, again, some of the negative outcomes. And I think our first presenter for the day outlined some of those issues. So ensuring that there's capacity at that level, thinking about strengthening regulation and monitoring, thinking about some of the configurations with supply chain. So pre-selecting of suppliers, price negotiation, contract management, making that increase controlled and centralized so that it supports the flexibility that you're providing at the decentralized level. So thank you very much, everyone. Thanks all of you for coming through. It's been quite a packed room. Thanks for taking your time to have these discussions with us. Thanks to all the panelists that we've had. Discussed and presented exciting pieces of work. And of course, thanks to ThinkWell, CGD, and the Kenya Wellcome Trust for organizing this. And with that, I wish you all a pleasant afternoon. Enjoy the rest of your conference. Thanks.